especially when it's involving joints. And the picture I have here is just an example of an infection that's infected the knee joint, and it attacks cartilage so quickly and bone so quickly that is something that we just need to diagnose as fast as possible. And imaging is one of our best ways to do that, along with clinical findings and laboratory findings. So basically, the modalities that we use in musculoskeletal radiology for infection are X-ray, which is always the initial evaluation. Sometimes clinicians will get excited because we have the access here. And a lot of times they'll go straight to something more advanced, like they'll try to go to CT or MR before X-ray. Really, we need the X-rays to see what's happening with the bones, because on MR it's not as easy to see what's happening with the actual osseous structure. So X-ray is very important for us to start with. Then once if we have findings on X-ray that are concerning, then we usually move on to more advanced imaging. MRI is really our study of choice for both osteomyelitis and soft tissue infections. CT is very useful for seeing the detail of the osseous structures. Also, a lot of surgeons need it for the anatomical markers for their surgery. So CT becomes almost more important for the surgeons than for our diagnosis of infectious disease. But it's also fast, and so time and money wise is much less expensive than MR. So sometimes the CT they'll go to first, because if we can rule something out on CT, then they can save time and money by not going to MRI. But MRI is our gold standard. And then ultrasound mainly is used for more superficial things, and also for our biopsies. You can see joint infusion on ultrasound, and organized fluid collections that we can put needles into to get samples of what's going on. So we'll start off talking about soft tissue infections, which include the three you see there: cellulitis, abscess, necrotizing fasciitis. And those are kind of in increasing order of severity and also emergence for surgery. Cellulitis is our most often seen entity, and basically the clinician sees a red indurated limb, and just from a clinical exam, if there's no obvious fluctuance, no obvious pockets of fluid by palpation, CT or CT is one of the first steps. MRI again is, I think, a little better, but we usually go to CT first, because another advantage of computer tomography is that we can see a larger field of view. So we can do a CT of an entire extremity, which can show us if there's, say it's a lower extremity, for example, if there's inguinal lymphadenopathy, but the infection is at the lower leg, at the tibia or fibula region. If we just do MRI, MRI is very localized to a specific body part. So we could only do portions of the tibia and fibula. We can only do the knee. So a CT, we can actually catch a larger field, a larger amount of anatomy on one study. So CT is actually good for that aspect too, when you have a large area of infection, to try to find any focal infections. But basically what we're looking for on CT, and you see with this image here, is you see skin thickening and induration of the subcutaneous fat. There's striations all through the fat there, which is indicative of edema, and the skin thickening is very pathognomonic for cellulitis in the correct clinical setting. Other things can look like this: renal insufficiency, lymphadenitis, those kind of things. But with the clinical findings of infection and laboratory findings, this is very indicative of cellulitis. And we move on to MRI. Once we pinpoint an area that we think there may be something more than just cellulitis, and this is more what cellulitis looks like. If you can see on the image on the left, this is a T1, and the areas of fat are all within this lower signal, which is fluid. If we had an organized fluid collection, you would see a little bit of mass effect or more organization of a collection. So without organized fluid collection, this is really indicative of cellulitis. And this is a contrasted image, and you can see all these areas are enhancing because it's all very inflamed and infected. There's the skin thickening here. One thing to notice though is that the signal stops at the fascia, which means it's just cellulitis. If it had gone beyond the fascia or there any organized fluid collections, you'd have something more like a myositis, or if there was signal in the bone moving into some areas of some bone infection. But this is what cellulitis looks like. Spares the muscles, but all of the subcutaneous fat is involved. And it's important to rule out those other things. And that's why we do this. And because cellulitis is really treated with just antibiotics, there's no surgical intervention for cellulitis, so it's important to rule out those other things. Soft tissue abscess is, of course, more of a serious problem. And what we look for on CT with this are areas of fluid that are surrounded by contrast enhanced soft tissue. So in this case, I know this streak makes it a little difficult to see, but it's next to the bone there. Let me see if I can, hopefully you all can see this pointer. But next to the bone here is a area of enhanced, this is all enhancing tissue here with these areas of lower attenuation, which indicate fluid. And if we were to put a region of interest to check the Hounsfield units here, this would be Hounsfield units of fluid. And so these are what abscesses would look like on CT. And then we move on to MRI, and it becomes a little more clear that these areas of low attenuation were fluid. This is a T2 image, and what you want to see in these is very fluid signal, not like this where it's kind of striated, it looks like there's muscle fibers within it. This is more of like a myositis, but this pure fluid here, especially with kind of a rind of tissue around it where the tissue is becoming indurated and thickened, that's indicative of an abscess. And here you can see there's peripheral contrast enhancement around these fluid collections. So this is very pathognomonic of soft tissue abscess, and important because this becomes surgical, at least to have our interventional radiologist place a drain, because decompressing these abscesses is crucial for them getting healed. And also something, if it's a large enough abscess, the surgical team will actually go in and do an I&D and clean these out and basically take out any loculations or extra fluid collections. They'll probe those and kind of get as much purulent material out as possible to help the antibiotics do their job. Moving on to even more of an immediate surgical emergency is necrotizing fasciitis. Very important to recognize on X-ray. If you can see, there's gas tracking along the soft tissues. An important hallmark of this is tracking. So if you have just a few locules of gas under an ulcer, say in the foot, that a lot of times is just local infection. It's local access from the outside to the inside within the soft tissues. So you get some locules of gas around an ulcer normally, but if the gas starts to go more proximally away from the ulcer and there's no wounds in this area, but you have gas tracking up, that's necrotizing fasciitis, which becomes a surgical emergency. Very important thing to recognize. You never want to see gas moving beyond where the wound is. And we have a CT just showing a little more clearly the gas tracking along the fascia. And you see here, this was actually a pretty advanced case. I think this had been there for a while. This is actually where one of the ulcers were, kind of in the mid leg, and this had tracked proximately outside the field of view, actually up into the thigh. So this was a pretty significant surgery afterwards to open this up and try to treat this necrotizing infection. Pyomyositis. This is when the infection has moved into the muscle. Actually, even harder to treat because it's harder for the antibiotics to access once it's kind of settled into the musculature. And for this, basically, you have a myositis, which is an inflammation of the muscle. And beyond that, you start to develop abscesses within the muscle tissue itself. And this can be very hard to treat and also requires surgery. A myositis without abscess most times can be treated with antibiotics alone, but this will require surgery because of the intramuscular abscess. So this is actually a step up from like subcutaneous abscess. It's much harder to treat, and it's a more involved surgery because now we're dealing with muscular involvement. Moving on, so now we're kind of in between soft tissue and bone. The joint, I guess, technically is soft tissue because it's synovium, but this is where because a bacteria, these are usually bacterial infections. A bacteria is confined to a joint space. It's almost like the body has its own little abscess formation because there's a pocket already available, and the bacteria just kind of sets up in this area, and so then it can just start attacking the adjacent bone. And I mentioned it earlier, but this is very important to recognize early because time is cartilage, and if this is allowed to go for any length of time, it will destroy all the articular cartilage in a joint very rapidly and start destroying the bone as it just continues to be destructive. And this is um, almost always surgical because they need to go in and clean out these joints to get most of the bacteria out and to decrease the bacterial load so that the medications can do the work. And this is something for us to recognize very quickly. And on X-ray, actually, the one on the left is the first film, and this is actually tough when you have an early septic joint because it just looks like really advanced arthritis. Sometimes you have other things to go on. If the patient had any previous films and you can see a rapid onset of degenerative changes, um, that a lot sometimes can be septic joint, along with the clinical picture of elevated white counts, other signs of infections, sedimentation rate, fever, those kind of things that you would see clinically. When you put all that together, the concern then becomes for a septic joint. So clinical picture is very important. And so if any of you are clinicians, letting the radiologist know the story is very crucial. We don't always have the luxury of knowing everything going on with the patient besides just the images, but it's an infection is a very important thing to know. And on the left, this was less than 1 month later. You can see there was rapid destruction of the joint. It's now dislocated. The glenoid is compared to this side is all but completely destroyed. There's bone here from just fragmentation. There's ulcerations, and this shoulder has been completely compromised by bacterial infection. So this was not seen on time. And I guess one thing that could have clued us in, it's very subtle, but there's maybe a locule of gas here. In retrospect, you look at these studies and you see, oh, this is what maybe we could have seen, but this would be very tough. And I actually don't know how this was read, but uh, this is what it looks like when bacteria is allowed to stay within a joint for any period of time. So we try to really be sensitive for septic arthritis because of the rapid destruction it can cause. There's a CT of the same patient just to really show you kind of things that were happening. You can see the destruction of the glenoid. This is the humeral head with multiple erosions. The articular cartilage is completely gone. The bone is eroded where the bacteria has destroyed the bone here. This glenoid has very quickly eroded and remodeled in that amount of time. And so it's a pretty severe case. And we'll talk about some mimickers just while we're looking at those slides. There's other things. Charcot joint can do the same thing, and we'll talk about a few mimickers later. But this just comes to mind when I see this. If you have a neurologic joint, sometimes with a like in our board exam textbook case is always there's a cervical syrinx, which just basically causes a lack of it's basically denervation of the shoulder joint. They can no longer feel pain, and a lot of times these will grind down like this as well pretty rapidly. But that's one of the things that can kind of mimic infection. But this was infection, and this is just another picture of the MRI, just so I can kind of show you some of those findings. Basically, we see a joint that has a very like kind of dirty fluid collection. It's very complicated, and peripheral enhancing synovium and just thickened synovium. And you can see again, like this is normal. This is normal cortex at the top, and this is where the cartilage. There's no cartilage here. The cartilage is completely gone. You would normally see normal cortex like this with like a thin layer of cartilage in the humeral head, and we have no cartilage and multiple areas where the cortex has been eroded away. And it's actually affecting the inferior portion of the acromion in this case. So it's a pretty severe case. Also to note on this one is the rotator cuff's completely gone. The supraspinatus muscle should be here, and it's gone too. But I have a feeling this patient just in particular had a chronic rotator cuff tear, because on the X-ray this is just secondary. But the acromiohumeral interval is gone, which means there's no supraspinatus tendon here to keep that away from just abutting the acromion. It's been going on for a while because there's remodeling of the acromion chronically. So this person probably had a long-standing rotator cuff tear. So this purulent material is now given even more free rein to go into the subacromial bursa and extend down into the subdeltoid bursa because they're connected. So this is a pretty extensive infection. Now we're getting more into bone specifically. One thing that we have a lot here is we have a lot of orthopedic hardware. I'm not sure how that is around the world, but in the United States, we do a lot of orthopedic surgeries. This is a hindfoot arthrodesis. This is a distal tibia and fibula with the intermedullary nail going, or the arthrodesis nail going through the calcaneus and the talus and into the tibia. And when we periprosthetic infections are very very important also to see, because these will not get better without surgical management, because the bacteria is settled in around the metal implant, and it just starts eroding the bone. The metal implant becomes loose because of the erosions, and things deteriorate also pretty quickly. And something you want to recognize on these is lucency, especially if it's new around the hardware itself. If you can see this kind of like there's osteolysis here. You start to get osteolysis along all the metal, and you can see here probably the infection probably started around the tibio-talar joint, because the erosions are kind of more so here. It's probably working its way up through. If this were allowed to progress, you would get loosening around all these screws and up around here as it worked its way up, and then pretty soon this hardware would be just kind of moving around freely within a cavity. Another thing is all this periosteal reaction is indicative of, especially this kind of feathery periosteal reaction, is indicative of an ongoing process, which in this case was infection. And you see like some erosive changes a little lower. This cortex is a little bit eroded. So there's a lot of signs of infection here, including all the edema. Just to distinguish from chronic periosteal reaction, this kind of smooth undulated periosteal reaction is more of a chronic periosteal reaction, likely from healing, or from, it could be things like renal insufficiency or just chronic edema. But this more feathery periosteal reaction is the periosteal reaction that we look for to try to suggest a infectious process. But when it comes to prostheses, really it's the osteolysis around the metal that we look for. The difficulty with these periprosthetic infections is CT and MRI are not very helpful. The streak artifact and the susceptibility artifact from the metal, especially adjacent to the prosthesis, which is where we actually want to see the most in our imaging, is just completely destroyed by artifact. So we actually can't use CT and MR very effectively on these. So we really have to go by plain films, and then we can consider nuclear medicine. I'm not a nuclear medicine physician, so I can't speak much to that. Well, I'm going to touch on it briefly here in a few minutes. And it seems to be, from my experience, very sensitive, not very specific. So a lot of times when we send patients to nuclear medicine, they'll say there's something there, and then we'll still have to biopsy it. And so really, if you can get a negative, it's great because it's very sensitive. But if it's positive, we still don't. I'm not sure what it is. And moving on to acute osteomyelitis, this is our most significant finding usually. It's in toes frequently. Like I said, we have a problem with diabetes in the United States, and a lot of times these toes become devascularized, deinnervated, and so infection is kind of running rampant in a lot of the toes. And this is a pretty good case of there's an ulcer, and subjacent to the ulcer, you have erosive changes of the bone. And as a hallmark for osteomyelitis, there, I would say over 90% of the time, probably more than that, you really want to see some kind of wound near the erosions, or you should think of other entities along with infection. So if there's no ulcer adjacent to a bone that looks like it has signs of osteomyelitis, then it could be something else going on. But with an ulcer adjacent and these findings on X-ray, it's pretty much slam dunk osteomyelitis. And like I tell some of the clinicians, if you can probe bone, there's osteomyelitis. The outside world should never be given access to bone, because there's just the skin flora is enough to infect bone if there's exposure. And so this is a pretty pathognomonic for osteomyelitis. And then moving on to MRI, if there is a question, say the erosive changes were not great, or another reason to do MRI is to see the extent. So back on that X-ray, we know there's osteomyelitis in this toe. We know there's these are pathologic fractures, since it's kind of fragmented. So that's also an important thing to recognize. But what we don't know is if there's osteo extending back along this first ray, or if it's getting into the second toe. And that's where MRI can come in and show the extent of the disease. So it also helps for surgical planning, because then they can see how far it's gone. So the MRI is still useful, even though we know it's osteo. An MRI is still practical to see. This is actually the same patient, and you can see this is actually distal metatarsal, but it's actually got some signal in there. And I just wanted to show you this because this is what we use and what we look for osteomyelitis. The three main things are marrow signal. And so there you have other secondary findings, like you want to see the ulcer. If you see osseous erosions, that clues you in. But the main thing we're doing MRI for is the marrow signal. So with a osteomyelitis, you'll have high T2 signal because it's inflamed, and normal T2 fat satted signal within a bone is low signal because the fatty marrow has been saturated, so that it's lower signal. So if you have on a T2 fat sat or a STIR, an inversion recovery imaging, if you have high signal, then that means that there's some kind of inflammatory process going on there. And then on T1, this is actually a contrasted image, but on our T1, if we have low signal, that means the marrow is being replaced by something, and it's usually cellularity. Mass lesions can look the same. This is basically just saying that there's something there that's not normal marrow, which you can see these other metatarsals have a normal marrow signal, which is bright fat marrow signal. This one does not. This is osteo. So it's enough for us if there's an ulcer and there's a high T2 or STIR signal along with low T1 signal to diagnose acute osteomyelitis. To make it a complete near certainty is if we have contrasted imaging and the marrow enhances. If you have marrow enhancement on top of those low T1, high T2/STIR findings, that's we would say without a doubt osteomyelitis, acute osteomyelitis. Okay, so that's acute osteomyelitis, very important. Chronic osteomyelitis. So this is when an infection has been in bone for a period of time. There's some chronic changes that happen and are important to recognize. And this patient actually has this particular patient has chronic osteomyelitis, and they I think had like a current infection, if I remember correctly, but it wasn't really a strong enough infection to cause surgery. The main findings were the chronic osteomyelitis. And those findings are you have thickened, undulated, chronic periosteal reaction. I mentioned earlier the difference between periosteal reaction that's chronic and acute. Acute periosteal reaction is kind of feathery and incomplete, where this is kind of undulated. It's like this undulated line of periosteal reaction. This is a chronic periosteal reaction. And it's the same here. You get this kind of just thickening of the cortex and these kind of undulating, smooth periosteal reaction. This is periosteal reaction that's been there for a long time. This is the area of concern, and you can see there's a little bit of less distinction of the bone here and a little bit less distinction around this cavity as compared to this one. So the concern here is for acute on-chronic osteomyelitis in this cavity. But multiple things that you will see are sequestrum, which are dead bone. Like this is a large sequestrum here within this cavity, and that's a clue that it's chronic osteomyelitis, because if it was like very active acute osteomyelitis, this bone would have been this would have been eroded, and this would be more of an abscess without bone in it. But when you have dead bone here, that means that this has just been sitting here for a long time, and this bone's been devascularized and just kind of dead. And this is kind of what a chronic would look like with the sequestrum. Cloaca is the term we use for a hole in the bone, and this is where um, there's been chronic access to the bone, and this just kind of matures and becomes ossified and becomes corticated and becomes a permanent kind of tract within the bone to this cavity. So if we look on MRI, we can see similar findings. This picture was just to demonstrate the cloaca coming out of the bone, and this is bone here. You can see that the bone is not. So this is a T2 stir, or it's T2 or a stir, but you can see here that the marrow within this is pretty dark, which is normal for a T2 or stir. So it's not currently infected. So this is a chronic osteo that you just see the cloaca here, but this is likely not acute on chronic osteomyelitis, which is why we do these studies to kind of see what's going on. And I do have some other things in case of this patient. There's edema here, which is difficult to distinguish denervation of muscle, which is becoming atrophic, versus myositis. So we have to kind of give that caveat. And then there's some kind of edema here, probably some cellulitis going on. But basically, there's not acute osteomyelitis in this case, likely. And here's just the picture of the tibia with the sequestrum inside. Pediatric osteomyelitis. I'm not a pediatric radiologist, so I do not get to see a lot of peds. Usually the physes are closed by the time I see these patients. I heard them talking earlier today about how we are sectioned off by musculoskeletal versus chest versus things, and so we actually have a separate pediatric section, and so we subspecialize so much that I rarely see peds. But in the case of pediatric osteomyelitis, of course, even more important because of the predilection for metaphysis, and with that predilection for metaphysis, unfortunately, it involves the physis, the growth plate, not infrequently in children. And it can actually, in children, go across bones very rapidly. It can go across the growth plate very rapidly, which can affect bone growth in those bones. So it's very important to recognize this early in kids. And one of the things that you can see is kind of a widening of the physis, particularly in children, because their physes are open. And because it goes to metaphysis, a lot of times you'll see erosions on either side of the physis. An important and very important thing to recognize. And there are different reasons for like something like an apophysitis. It can also be traction, other things, but with correct clinical picture, you really want to rule out osteomyelitis in these kids. I just had to throw in something just one more time with diabetes because it's such an important thing here. But basically, diabetic foot, you get the ulcer, and this is what I was saying before, how you can have gas just around the ulcer. This is really probably a local infection or even gas tracking in, where here there's you don't see any gas tracking up to be concerned for necrotizing fasciitis, as we discussed a little earlier. This is what diabetic toe looks like, and often they have these pathologic fractures that go along with it. And the dangerous thing, of course, is the denervation and ischemia. So a lot of times patients won't know, like they don't know they have an ulcer because they can't feel these toes, and so things just progress. By the time we see them in diabetic foot, sometimes they're pretty advanced because but they were just undetected until the patient went to the doctor and they saw something there. So very common complication, very serious, and usually requires surgical amputation of these digits and even the forefoot in a lot of cases. I threw in a slide for nuclear medicine. My experience with nuclear medicine is that if we see something on MR, nuclear medicine may not be incredibly helpful, even if we're not sure if it's infected or not, because, like I said, it's very, very sensitive, not very specific in a lot of cases. Sometimes the tagged white blood cells, the indium gallium scans can be a little better, but if they see some tracer uptake in those regions, a lot of times it's kind of a differential, which then still includes infection. So a lot of times these go to biopsy, regardless. Where it becomes important, I mentioned before, is when it's periprosthetic. And this one, I know it's probably difficult to see, but you can see there's this area of like photopenia here and here. These are bilateral hip replacements. These are the prostheses going here. So that's why this one went to nuclear medicine, because if we would have done an MR to try to look for this infection, which this was infection, but in order for us to look for that infection, we wouldn't be able to see it on CT and MR because of metallic artifact. So this is where nuclear medicine is helpful for us, in um, detecting these infections when we can't see them because of metal artifact. And some other diseases that are a little more insidious. Tuberculosis is one that's tough for us sometimes, because for some reason it doesn't cause a lot of symptoms until it's really, really bad. A lot of times these will just kind of just grow and kind of get worse and worse. It'll get to multiple levels of the spine. The spine seems to be where we tend to see it the most. And you end up getting a gibbous deformity, which is kind of like what's happened here. You get infection that's destroyed vertebrae, and they get a focal kyphosis. And a lot of times it gets this far along before people realize what's happening. And it's unfortunate, but tuberculosis infections are difficult, and they're difficult to treat. They're difficult to detect. So this is a pretty bad actor. But you can see on this case that there's pathologic fractures of these vertebral bodies. There's fragmentation. This is all kind of purulent material. There's perispinal involvement. This is going anteriorly outside the joint. There's involvement of the spinal canal. I mean, this is a very serious case, and like I said, unfortunately, they just go detected for too long sometimes. Fungal infections also are hard because they're hard to treat, hard to diagnose. A lot of times, people will get these infections, and they'll be treated as a bacterial infection, and of course not get better because they're not a bacteria, they're a fungus. Some things that can kind of clue us in are multi-levels that are separated. So a bacterial infection will stay within adjacent levels of the spine. Or sometimes fungal infections, they'll a lot of times we'll think it could be neoplasm, because you'll see some here that it'll skip, and you'll see some here, which seems probably the main area where they saw it. But then you'll kind of get signal, and things will skip, and they'll end up at different levels. And this is kind of what a fungal infection can do. Some fungal infection can do, and so this is a hard one for us to treat sometimes too, because fungal infections are a little bit tricky for the ID doctors, and especially when they don't have the diagnosis early enough, because bacterial infections are so common that a lot of times it's mistaken for that. It's a little difficult. We do some mimickers of joint infections. Charcot arthropathy is one thing that's hard for us. The overlap in both X-ray and MRI of a Charcot joint is enough to where sometimes we can't tell if it's infected or if it's just a denervation arthropathy. And the bad part about that is they both happen in diabetic patients. Like, diabetic patients are because of denervation, they're the ones that get these Charcot joints. And since they're difficult to tell between that and an infection, a lot of times they require biopsy. A lot of times they require follow up. The difficult thing there is Charcot joints can progress rapidly too. So this is where sometimes a tagged white blood cell scan, because it is a little more specific for nuclear medicine, sometimes will help. But these are difficult. These are difficult to diagnose, and so many times we end up having to put a needle into a joint space and see if there's bacteria in usually one of the metatarsal or talonavicular joints, to try to see if there's anything that's bacterial going on in there. But these are difficult. And yeah, so this is almost more of a clinical diagnosis because imaging really has a hard time telling the difference between those two. Um, some tumors. I still have that slide there. Okay. The this talus is actually was lymphoma, but at first it was thought to be infection. I mean, the patient was having abnormal white blood cell counts because of the lymphoma, having pain, redness, all those things in their ankle, and this is actually what diagnosed their lymphoma, was this kind of single osseous finding here that we thought on imaging could have been infection because it has the high T2, the low T1. It enhanced on contrast imaging, and so it's the all the hallmarks of infection, and this one happened to be lymphoma. So even when sometimes we think that we have infection, sometimes it's not. So we have to keep those other things in mind. There are mimickers, and this is one of the ones that can trick us sometimes. So try to make sure we finish on time. Okay, so we have a diagnostic pathway. Quickly, the clinical suspicion is, of course, the most important thing. There needs to be signs of infection before imaging is done because there are, like I said, many mimickers. And if we go by imaging alone, we're going to get it wrong. So we need to know the story of what's going on with the patient. And then we do the initial x-ray, and the x-ray should always be the first line. And that way we can make sure that it's not a fracture, because sometimes fractures will cause, I mean, they'll cause pain, swelling. They can cause people to have constitutional symptoms because of pain. And so make sure it's not a fracture causing these findings. It's important to do x-ray. That's another thing, that if a fracture on MRI, because the bone is not as well delineated, MRI can look like infection because you'll have all the same things. You'll have marrow edema because of the fracture, and you'll have enhancement because of the healing. And so it's important to do an x-ray to rule out those things. And then advanced imaging we've talked mostly about today. So that's the things we look for on CT and MR we've talked about. And then biopsy is our definitive diagnosis, and we do a lot of that in our service here. We do a lot of biopsies for infection, for neoplasms. And just some pearls take home. I mentioned multiple times, x-ray is first step. MRI is gold standard if it's indicated. Many things can mimic infection, so it's always good to keep other things in mind, like trauma and neoplasm, especially. So always correlate with the clinical data, and definitely early identification leads to a better outcome. And that's cool with most things. We only have a few minutes, so I'm just going to briefly show you just a few cases, just so you kind of can see what some of this looked like in real time. This was a 50-year-old that had knee pain, and on this image there was an effusion. Not much to go on here. The joint space looks pretty good, and mainly it was just an effusion. So this will be one that would need to go on clinical findings, because if we just have this, we would say this was pretty nonspecific. A lot of times we will say sterility indeterminate for a knee joint effusion, but knee joint effusions are not routinely aspirated for infection unless there's clinical signs. So this was 1 month later of the same patient, and now you can see the joint space is gone. There's a locule of gas in the joint now, and so this is more. If you see this, then you start thinking infectious process, especially if you have that first image where you can see the difference. And here's the comparison. This was the initial image. 1 month later, joint spaces were gone, and you can see there's kind of periarticular osteopenia. Some of the bone is starting to be affected. And this was an MRI on the same patient. And this is our low signal T1, and this is our high signal on T2. And so this was a infected joint. Something else, just quickly while we have this, is this here is not infection. So if you can see the difference in how well demarcated this low T1 is, this is probably bone marrow reconversion or something else going on. For osteomyelitis, it's usually adjacent to whatever the infectious problem is, and the marrow signal is more kind of, I say mushy to the residents, but it's just kind of less well defined. It's dark. It's definitely different than normal, but it's kind of hazy dark and not well demarcated dark. So that's also something else to look for when you're looking for your T1 changes. Next case, this was a 50-year-old person with diabetes. I actually showed this one earlier this is one I showed earlier for the toe. And basically what's important on this one is I actually showed this case to you twice with kind of that you knowing, because this person on the edge of the field over here, and this is an important thing to look at when you have an infection in a distal part, always look proximal to see if there's any gas tracking anywhere. This person had gas here, which was separate from the actual where the actual ulcer was. And so then follow-up lower extremity was the case that I showed you of necrotizing fasciitis. So those two cases were actually the same case I showed, both for the toe and for the necrotizing fasciitis. And so it's important to look. We say, you know, the forest for the don't lose the forest for the trees. Basically, you see this and you want to not have satisfaction of search, check the whole thing, because if you have something on the edge of your field over here, looks like gas, then it's good to go ahead and get the rest of the limb, and that's where we happen to see all this. I showed you these pictures earlier of the CT. This was our case I showed earlier with the arthrodesis with the infection. This was actually before the prosthesis was infected. There's no osteolysis next to the tissue here. All of the periosteal reaction is this smooth, undulated periosteal reaction. It's not feathery or kind of broken. This is probably just mineralization in the syndesmosis, but you can see it's all kind of smooth and solid. This was bone graft material that was starting to mature. And then the picture I showed you was approximately 1 month later. And now we have this lucency. You can see there's a space here between the bone and the prosthesis, and the lucency started. You have all this feathery edema that we talked about. I mean, periosteal reaction we talked about earlier. And so that's in this lucency here, that's a sign of infection. So looking at those two, I don't have it side by side, but you can see there's no lucency, and then here you can see the bone goes right up to the prosthesis, and then on this one there's lucency on either side of the prosthesis, and that was the infection. And then this is what they did surgically. They removed the hardware and put in a antibiotic cement spacer to let the bone heal and give some antibiotic treatment at the same time within that cavity. Diabetic toe. This one, just one more time. This is a big edematous toe. Unfortunately, it's covered by the big toe there a little bit, but here's where the real findings are. It's some erosive changes of the head of the proximal phalanx. And here you can see that it's dislocated because the joint it's infected the joint, and there's an ulcer up here that's difficult to see. But there was an ulcer adjacent to the bone. And I believe in this one the bone was exposed, which I was saying before. If the bone's ever exposed, there's osteo. It's just it's not gonna not be infected. And this was an MRI of the same case. This is the contrasted image in the middle. This is the stir, which shows, you know, normal low marrow in most of the bones, and then high signal in all these bones that were involved. And this is the T1 with the low signal. And then I'll get one more case. I'm a little over from what I was aiming for, but this one I just want to show you. This is a really interesting case. So this is the last one I'll show you, but basically this was a 15-year-old that had thigh pain. And so we get this x-ray, and if you can see if it's sharing on your screen well, there's lamellated periosteal reaction and this primitive lesion. And in a teenager, when we see lamellated periosteal reaction and a infiltrative lesion, our top differential is Ewing sarcoma or osteosarcoma. That's very hallmark for our board exams here. That's one of the we call them buzzwords, which are words that when you see them, it's almost pathognomonic for a specific diagnosis. And lamellated periosteal reaction, which is this kind of striped periosteal reaction in a young person, is almost pathognomonic for Ewing sarcoma. And then this was the MRI, which also was pretty scary. You have this area of abnormal marrow on T1 replaced here, T2 here, which, I mean, low on T1, high on T2 is infection, but with no ulcer near this patient or near this wound, I mean, we just thought it was cancer. Did a MRI. You can see on this cross section of the axial of the MRI, you can see there's thickening of the cortex. This is the permeative involvement. There's some soft tissue findings. We did a biopsy, and it was an infection. And so this is infection mimicking another diagnosis rather than the other way around. But this is this is a very interesting case. This was pretty recent. This was just a few weeks ago. So this is pretty fresh on our mind. But yeah, that's that's what I have for y'all today. If you have any questions, I believe they're in the chat, and I will try to answer those as best I can.
Thank you, Dr. Powell. Thank you very much for your insightful presentation. We have one question in the Q&A box. Is it possible to differentiate between septic arthritis and acute osteomyelitis on imaging?
Yeah. So on X-ray, um, if it's early septic arthritis, it's pretty tough because at most what you'll see is an effusion. Um, then once it progresses, it actually will have some osteomyelitis. So it will extend from the joint into the bone once it gets a little further along. By the time you have erosive changes to the bone, then that is osteomyelitis complication of septic arthritis. So, like I was saying, the clinical picture is very, very important. If you have a clinical picture that sounds like infection and you can see an effusion on an X-ray, then getting a needle in there, because on imaging, I guess the answer is no before there are osseous changes. Even with the MRI, you still can't tell why there's an effusion. There are inflammatory arthritides that will cause effusions, and also inflammatory arthritides that will cause um, erosions. But those erosions are normally we call them juxta-articular for say gout or any of those kind of like inflammatory crystalline or non-crystalline inflammatory arthritides. The erosions are actually on the side of the joint because the articular cartilage becomes a little bit protective of those crystals. So the erosions are more on the side. Where with if it's like an infected joint, the cartilage is destroyed and the erosions are on the articular surface. So that's one way you can tell the difference between an infectious like a septic joint and an inflammatory arthritis is where the erosions happen. But as far as on imaging telling an early septic arthritis, I don't know if you can without tapping the joint and seeing if there's bacteria in there.
Okay, thank you. We have another question.
Sure.
Can we differentiate between bacterial infection and tuberculosis based on imaging?
No, and that's one reason why tuberculosis and fungal infections are scarier. I mean, they tend to be indolent and kind of hard to treat and just sit there for a long time. But bacterial infections can do similar things. They just act a little faster. So if there's rapid progress, it's more likely bacterial than tuberculosis. But really, it requires biopsy to know for sure.
So we cannot solely base our imaging only on imaging, right?
Right. Yeah.
Diagnosis.
Yeah. And
Uh,
and standard diagnosis is always going to be biopsy. Yeah.
okay. Is there any other question from our participants? Can I also ask a question, Dr. Powell?
Sure.
I'm curious about your slide about septic arthritis, the one with right shoulder, I think.
Mhm.
If we only have the image from one view, like in your slide, only AP view, I cannot see if there any sign of key that you can say there is septic arthritis going on in that shoulder because it looks like only rotator cuff arthropathy, only from AP view.
Yeah.
How can you tell is there any septic arthritis going on that shoulder?
On the X-ray.
Yes, the one that you present before.
Yeah. And that's the difficult thing, and why we need clinical evaluation. There was one. I think there may have been a locule of gas on that one, but there's not always going to be a locule of gas. So many times the clinician's expecting infection, and so if we see a joint effusion, then we will say sterilely indeterminate joint effusion, and they'll either then tap the joint or move on to something like CT or MRI. So no, you can't tell on a single image, especially when it's early on an X-ray. There would be no way to tell that it's septic arthritis if there's no secondary signs like infection or something like that, or if there are things like gas in the joint, or if you see that the degenerative changes, if you happen to have an earlier picture of the patient and you see kind of rapid onset quicker than you would expect, then there's probably an infection. But you're right on that on just an AP view of the shoulder, um, especially an early septic joint, you wouldn't be able to tell the difference.
Okay, thank you.
Mhm.
We still do not have question from our participant. About sarcoidoid and septic arthritis, is giving contrast to MRI will help to differentiate those conditions?
Yes, because a Charcot, well, it depends. So like a shoulder, I think you may be able to tell just based on the induration and the synovium, but
Hmm?
other Charcot joints you cannot tell the difference at all, and that's one of the hard things about a Charcot joint, especially in the foot. When we have foot Charcot joint, the overlap of imaging from the Charcot joint and infection is there's so much overlap that we sometimes can rely on nuclear medicine tagged white blood cell scans to see if there's a lot of inflammatory like infectious things happening there, but a lot of times that will require a biopsy or follow up. I mean, it's unless there are strong signs of infection clinically,
Hmm?
Charcot joints are common, and so a lot of times they'll just kind of follow them up and watch them if there's no constitutional signs of infection. If there are, sometimes you'll have to just check the joint space and see if there's
So
anything.
so
Yeah,
giving
and
contrast will not help,
no, because it
giving like
because
gadolinium.
no, because the Charcot joint will enhance all that marrow will enhance into Charcot joint as well.
Oh, I see.
Yeah. So it all kind of it's there's a lot of overlap. And the thing is, a lot of times on the diabetic patients, we can't do contrast because their renal
Hmm?
function isn't great. So a lot of times we can't even attempt contrast on those Charcot joints, which of course makes it even more difficult.
Okay, thank you.
Mhm.
Mm, about periprostatic infection, is there any role for ultrasound? I guess from your pathway, you do not mention the role of ultrasound in musculoskeletal infection.
Yeah,
Do you
we
think
don't.
it is not used or any other reasons?
Yeah, so it's difficult for ultrasound for us anyway, as far as for me. I'm not very good at ultrasound, especially if I don't think because of bone. I don't think we can see inside the bone very well. So the prostheses, if they have abscesses, then ultrasound would be good. And I guess that would be one thing you see with ultrasound. Like if you're scanning over a prosthetic limb and you see a fluid collection, that would probably be pretty indicative of, and also that would give you a target for biopsy. Excuse me. So that'll be another good thing for ultrasound in those cases. Because if you see an adjacent bone adjacent fluid collection, you can put a needle in it with ultrasound. That'd be good. But as far as diagnosis within the bone itself, I don't think it's very useful.
Okay, thank you very much, Dr. Powell. We'll almost reach 9 p.m. in our time in Indonesia. So I guess we come to the end of our session. Thank you very much, Dr. Powell, for your comprehensive presentation.
Of course, it's a
And
pleasure.
thank you for all participants for your engagement and question. On behalf of the Academic Radiology Education Program and all organizing institution, I sincerely thank you for joining us today. Stay safe and we look forward to see you in the next webinar. Have a great day and evening wherever you are. Terima kasih. We're back to Dr. Terpeding.
Thank you. Thank you. I'm going to spend 2 minutes here again to wrap up the end of the webinar. Can I share my screen? Please. I'm going to share my screen.
I'm clicking stop share.
Oh,
It says Zoom meeting is not responding. So when I click this, it may kick me out of the
yes,
webinar.
that's why. So because I'm doing the housekeeping, Dr. Paul and Dr. Salayavati, you can leave if you want to. No,
Okay, well,
yeah.
thank you very much. It was a pleasure, and I'll see you later now.
Thank you.
Thank
Thank you.
you.
All right. I would like to share my screen here. I'm going to do it again. IT team, please help me. Okay, got it. Thank you. Thank you. Okay, here is the news from me. Do you see my screen, right? Do you see my screen?
Not yet, Doc.
Oh, okay. Okay, let me do it again. Thank you. Thank you. Okay, I'm going to do this. And now, what about now?
Still no.
Oh, okay. Okay. I'm not sure. I'm sharing here. Screen 2.
Yes.
Thank you.
It come out
Thank you.
now.
Okay, thank you. Thank you. Thank you, Sani. So this is again the contact information that you should have if you have any questions. So we at the by October we will have a meeting with the education committee again to pin down the topics for the next year. Any topics you want to hear, email Dr. Wind at this to her email address here, thaiwind@gmail.com. For the IT issue, please contact the IT team from Vietnam. It is arep2025.it@gmail.com. For the membership,
Dr. Net, I'm sorry for interrupting. Can you press F5 to make the slide full screen?
okay. If I actually I did the somehow it not it is F5. I'm in the presentation mode, but it's probably just very small, I guess. Okay.
Yes, it
And
is small.
is it very small, right? Okay, let me I'm gonna do it. Let's just okay, I'm sorry for that. Let me share it again. So apologize for that. Don't know how to make it bigger here. And I'm gonna share it again. Okay. I'm not gonna change. I'm not sure how you see it. Do you see it at all?
Yeah, we see it, but still the same as before.
Okay, I cannot make it bigger, Sani. I'm
Okay.
sorry. So I have to go. So the next one is about the you may get a weird email. So please subscribe to it so you can get connected with the program so you know what's going on here. And so it's not a spam. And so please register. And the next one is okay, the next session is MI staging of rectal cancer. Our speaker is from University of Texas MD Anderson Cancer Center. This is a very good, the #1 cancer center in the United States for so many years. So they have a lot of good technological advancement over there. So please join us for the MRI staging of the rectal cancer. And our speaker is Dr. Morani. And in this month, we have an ASCII meeting in Busan, Korea, and we work radiology excellence program work with 2 radiologists and with radiologists and radiology residents in Laos. We submitted 2 presentation over there. It's got accepted. We finished with the submission. One is about the CTA in anomalous origin of coronary artery. And the second presentation is a role of cardiac MRI in myocarditis. So we work with these 2 people from Laos. And we submitted 4 abstracts to Korean Radiology Society meeting in Seoul, South Korea, 2 radiology residents from Cambodia, and 2 radiology residents, which is from IT team from Vietnam, to this meeting, which is going to be, I think, by the end of the year in October, if I'm right. It's in October, in September, sometime around that. So all of these submission are in Radiology Excellent Program. If you want to know more, you can ask me about it, because we select people who we will work with and who will go. We cover the expense for the airfare and the hotel and the meeting registration for person who gets selected. Okay, if you want to know more details, just email me at my email address. And that will be it for today. And we'll see you in the next 2 weeks. Thank you.